imaging of bowel and mesenteric injury. To start with, hollow viscous injury and mesenteric injury, they are very rare when compared to the visceral injury. It's seen in approximately 5% of patients who succumb to severe blunt abdominal trauma. In the order of occurrence, small bowel is more involved than the colon than the stomach. And the exact site of involvement is proximal jejunum, just distal to the ligament of Treats, and distal ileum, proximal to the ileocecal valve. And whenever a patient has chance type vertebral fracture or has a large abdominal wall hematoma, they have a higher risk of injury to the bowel or mesentery. Now let's see some of the signs which have to be seen in the CT imaging of the bowel and mesenteric injury. So primarily, bowel wall discontinuity. It is highly specific but has a very less sensitivity. And next, the extraluminal oral contrast material. Even this has 100% specificity, whereas the sensitivity is very low. Extraluminal air loculi has slightly more sensitivity and specificity when compared to the other findings. Focal bowel wall thickening has increased sensitivity and specificity. Abnormal bowel wall enhancement, we do not see this regularly, so this has increased specificity. Mesenteric infiltration or stranding has both increased sensitivity and specificity. Free peritoneal fluid has more sensitivity when compared to the specificity. So the idea of saying sensitivity, specificity is we should look for these findings when we are dealing with a case of trauma, especially the bowel or mesenteric trauma. As we saw this table, we can see the more specific signs, they are not highly sensitive, and vice versa, the more sensitive signs are not highly specific. So the presence of combination of these findings is what is going to help us out in identification of the injury. So to start with, bowel discontinuity. It is a primary finding of bowel injury which is very rarely seen, and it's a very unusual finding, but it has 100% specificity. Extraluminal oral contrast material, yes, it has 100% specificity for bowel perforation, and it has very less sensitivity. As we can see in this case, the extravasated oral contrast is seen on the lateral side, and this is the free intraperitoneal fluid, and there is extraluminal air loculi are seen in two different places. One is intraperitoneal extraluminal air loculi, and this is retroperitoneal extraluminal air loculi. So to put together all these things, yes, these are indicative of bowel injury. Next is the extraluminal air loculi. In the setting of duodenal trauma, yes, it is very important, but just extraluminal or extraluminal intra or retroperitoneal air is not per se diagnostic of bowel perforation, because it's also seen in other conditions such as barotrauma, mechanical ventilation, air induced during CT cystography which can escape through a bladder laceration. Intramural air. Intramural air tells us that there is a more likely to be a full thickness injury of the bowel wall when compared to the partial thickness injury. And as we can see here, there is minimal amount of interloop fluid which is pointed out by these arrowheads, and there is intramural air in the ileal loop, so which is abnormal and tells that is a site of bowel injury. Next, coming to the bowel wall thickening. This is a very important finding. It tells us where the site of injury is. So bowel wall thickening is seen in 75% of transmural injuries. It's a more sensitive finding for bowel wall injury when compared to the extravasation of the oral contrast, or pneumoperitoneum. How do we say a particular bowel is thickened or bowel wall thickening, abnormal bowel wall thickening? There are two criteria. The first one is there should be disproportionate thickening when compared to the normal segments. For example, if we see this bowel or this bowel in not even this one, there is disproportionate thickening. And the second point is the bowel wall thickness greater than 3 mm with adequate bowel distension. We cannot say that bowel wall is thickened when there is under distension of the bowel, of a particular bowel which is in question. So based on these two criteria, it's considered abnormal. So as we can see here, there is circumferential wall thickening of the bowel loops and not much stranding as we see in enteritis. And there is also extravasation of the contrast, and there is intraperitoneal fluid, and there is extraluminal air loculi. So all these put together tells us that these are the ileal loops. So ileal bowel loops, jejunal loops. So jejunal perforation is the cause for all these things. Bowel wall enhancement. The reason for abnormal bowel wall enhancement. So first let us see when to call it as an abnormal bowel wall enhancement. When the enhancement of a particular bowel is greater than that of the psoas muscle. For example, here, when compared to the psoas muscle, the bowel wall of the ileal loop is more, or enhancement is equal to that of the adjacent vessel. So either of these criteria will tell us that the bowel in question is abnormal with respect to enhancement. The proposed cause for this enhancement is that there will be reduced perfusion, so there will be interstitial leak of the contrast material, which fits into the category either a local vascular damage related to bowel or mesenteric injury, or another condition called as systemic hypoperfusion complex. So in these three conditions, we can see the bowel wall enhancement, abnormal bowel wall enhancement. Mesenteric infiltration is a more non-specific finding. Infiltration or stranding, mesenteric infiltration or stranding, it can be seen with the bowel injury or without the bowel injury. When there is bowel wall thickening with adjacent mesenteric fat stranding or infiltration, it goes more in favor of bowel injury. But here we can see in this case, there is a mesenteric hematoma with adjacent mesenteric fat stranding. So this is in favor of mesenteric injury than a bowel injury. And mesenteric findings are more common to occur when the bowel injury is along the mesenteric border. A localized hematoma within the mesentery, in the absence of a bowel abnormality, it points to an isolated laceration of a mesenteric vessel, as we see in this case. Next is the intraperitoneal and retroperitoneal fluid collection. Retroperitoneal hematoma, along with the wall thickening, it helps us in identification of the duodenal trauma. For example, here, the duodenal wall is thickened and there is adjacent fluid, and there is also the fluid is hematoma. This here it looks hyperdense. So hematoma, retroperitoneal hematoma is seen adjacent to the vessels. So hemoperitoneum is a common finding in patients with intraperitoneal bowel or mesenteric laceration. Periduodenal hematoma is a very specific, fairly specific sign of duodenal injury, because in retroperitoneum the blood tends to localize at the site of injury. And hemoperitoneum in the absence of a solid organ injury should imply it would imply that bowel or mesenteric laceration is a source of bleeding. So we should raise a suspicion when we don't see any visceral injury but only hemoperitoneum. And here, in this case, it's even more clear. So we are seeing a thickened duodenal loop, and immediately adjacent to it is the fluid collection. So this is a case of duodenal laceration. These are the this is a patient, 46-year-old woman who presented with jejunal laceration. The findings we see here is the thickened jejunal loops which are marked with J, and there is fluid, intraperitoneal fluid collection. In addition to this, there is active contrast extravasation. The more distal images of the same patient demonstrate more active contrast extravasation and thickening of the jejunal loops, and there's pneumoperitoneum. So to put together, these findings are suggestive of bowel injury, mainly the jejunal injury, laceration. Although we are not seeing here, there is discontinuity of the jejunal wall, which is very rare to be seen. This is a case of an automobile crash where we can see a large amount of fluid collection in the abdomen. We can also see a splenic laceration here, and there's a large hematoma surrounding the vessels, and there is hemoperitoneum, and there is abnormal enhancement and wall thickening of the ileal loops, distal ileal loops. Abnormal because it's almost equal to the enhancement is equal to that of the vessels. So this is a case of ileal perforation along with splenic laceration. This is a patient who met with a motor vehicle accident, and the findings include there is thickening of the large bowel loop, predominantly the ascending colon, marked wall thickening, pneumoperitoneum, and there is hemoperitoneum, especially in the pelvis. So this is a case of colon injury, especially involving the ascending colon. There is another entity called as hypoperfusion complex. Hypoperfusion complex includes collapsed infrahepatic IVC, there is flattening of the renal veins, decreased caliber of the aorta, diffusely thickened and hyper-enhancing small bowel called shock bowel, increased enhancement of the kidneys and adrenals, decreased enhancement of the spleen, and pancreatic enlargement with peripancreatic or retroperitoneal edema. There's another entity like when there is fluid overload, we do see diffuse bowel wall thickening and edema. But the differentiating points between the fluid overload and hypoperfusion complex is here the inferior vena cava and hepatic veins, they are rather distended when compared to the collapsed state in the hypoperfusion. And liver may demonstrate heterogeneous pattern of enhancement, that is a nutmeg appearance, or sometimes a concentric halo of low attenuation, that is a collar around the portal veins, which we see in fluid overload or overhydration. And the other abdominal organs and vessels will have a normal appearance, whereas here we saw regarding the renal veins, aorta, IVC, and spleen and pancreas, all these findings, which won't be there in this condition. Let us see an example of this hypoperfusion complex. We can see marked wall thickening of the colon, especially the ascending colon, and there is hyper enhancement of the small bowel loops, mainly the jejunal loops, and we can also see that the IVC is collapsed in this, and there is hyper enhancement of the or increased enhancement of the adrenals and kidneys, and decreased enhancement of the spleen. So to put together, all these findings are suggestive of hypoperfusion complex. So to summarize the findings, which are more important when we are dealing with the bowel injury, the findings which are very specific to bowel injury is bowel wall discontinuity. Second is extraluminal contrast. Then extraluminal air loculi, which can be either intraperitoneal or retroperitoneal. Findings which are less specific to bowel injury are bowel wall thickening, abnormal bowel wall enhancement, and mesenteric findings. Findings which are very specific to mesenteric injury are mesenteric extravasation, mesenteric vascular beading, or termination of a mesenteric vessels, abnormal termination of a mesenteric or cutoff of a mesenteric vessel. Less specific findings of a mesenteric injury is mesenteric infiltration, mesenteric hematoma, bowel findings. The common features which are seen in both the conditions, that is the bowel and mesenteric injury, include the intraperitoneal and retroperitoneal fluid collection and abdominal wall injury. They can be present in both. So these are the findings which should be kept while reading a case of bowel or mesenteric trauma or a blunt trauma to look for bowel or mesenteric injury. Any questions? Most of the images have been taken from the journal, so I've quoted the reference then and there itself.